anywhere in the few weeks later, lately. Um, when she came to the ER, the blood pressure was 110/55. The heart rate was 105. The respiratory rate was 22. The SpO2 was 95 on room air. She was in mild distress, and she had upper abdominal pain in the exam, but the rest of the exam was mainly normal, and no other findings relevant. I'll say that the abdominal pain was without guarding or rebound, and yeah, I'll leave you there.
David, thank you. And since we recorded started the recording a bit late for people just watching later asynchronously, we were just basically a minute into the start of the case. That actually, and there was quite a bit of information presented in the first aliquot. So I guess maybe we could just take a few seconds, take a minute to just kind of catch up mentally and process the information so far.
Great.
Based on what we've heard and what notes were taken.
Just to do a brief recap, it's just a 57-year-old woman without any relevant past medical history apart from Graves 15 years before, that presented with upper abdominal pain for 3 days, and also complained of kind of mild asthenia in the last 3 months, but without any other symptom. And the physical exam is just remarkable for, she was a bit tachycardic, and she had upper abdominal pain on palpation. Yeah.
Thanks, David. So, upper abdominal pain, very common symptom. Probably most of us at some point have had, 3 days of pain or tenderness, just a little bit of what some people might call perhaps dyspepsia, right? Kind of upper abdominal vague discomfort, often associated with food. We haven't necessarily gotten that detail. It would be interesting to follow up and ask whether it is associated with food intake or relieved by food. And I think that can just come from everything from a little bit of reflux to stress to gastritis, or just be kind of a secondary functional symptom of a systemic illness, viral or otherwise. I think so anytime I'm kind of thinking about a common symptom that is very nonspecific and most of the time has a benign and self-limited etiology, I'm in a frame of mind of being very vigilant for any kind of red flags or yellow flags, anything that makes you sort of reframe the problem into a different problem, or makes you have to slow down and consider more important, more sinister, non-self-limited processes that are actually important to identify, name, and modify. And I challenge everybody, I guess just with that frame, which is one of many frames that you could use to start kind of analyzing this case. What is a red or yellow flag here? What do people think? Please unmute or type in the chat. Like, what makes you think this isn't just, something that's going to get better in the next day or two? Okay, so Elena and Eliana are both saying that, there seems to be maybe a longer history than just the 3 days, right? So she was previously healthy otherwise, but as part of the initial history, we're hearing she hasn't been quite right otherwise for more than just 3 days, right? And of course, just kind of asthenia, tiredness, just not feeling quite quite at your best, again, could be very nonspecific. It could be circumstantial, and it'd be really important to understand the degree of that, and whether it seems to potentially be pathologic and be related to this. But that's definitely one, right? Anything that changes the potential time course beyond just a few days. Vijay saying the tachycardia, absolutely. And Ethan kind of helpfully highlighted that as an abnormal vital sign. Definitely a big one too. Any others? So did we hear about Melena, Elise, or is that something that you would be wanting to look for? We heard about Melena?
No, I
Yeah.
think she's saying that would be a concerning sign.
Right. Yeah. Sorry, misunderstood the question.
Yes, no, thank you, Elise. Actually, that's a great question too, right? There's information that came to us, but part of what we're supposed to be doing if we're trying to kind of practice and imagine what this actual encounter would be like, how we would not only process information, but what information we would seek to process. I think that's always a good exercise too, to kind of think about what else is a relevant piece of information we don't have yet. And that would absolutely be a red flag, or should I say a black flag, right? But whether there's any color flag coming out the other end that isn't a normal color, that would absolutely be important, and it would kind of localize this process to the GI lumen, right? Because otherwise, that's not necessarily the world we're in. This could be a gastric duodenal esophageal process, but it could also be pancreatic. It could be peritoneal. It could be still musculoskeletal or cardiac, or anything near that anatomic part that's actually hurting. But luminal GI symptoms like blood would definitely sort of narrow the differential substantially.
I've been thinking a little bit about the background that we were given from David about the Graves and how it plays into this, if at all. So I think there's a couple sort of categories that I've been thinking of that I think generally is a way to think about a known prior medical condition in the context of a new symptom. I think the sort of categories to think of are, they're totally unrelated, which could be possible. The prior condition is back and is in fact a major explanatory force behind the current symptoms. The prior condition's treatment has resulted in the current syndrome, or the prior condition is associated with other conditions that could explain what's happening here. So it's possible the Graves has nothing to do with it. Could recurrent hyperthyroidism, knowing David told us she's off treatment, cause epigastric discomfort? Yeah, definitely. I think some people already put some ideas in the chat just about increased kind of gut motility. Classically, we think of like hyperdefecation, having more stools than frequent, although not necessarily increased volume, which is a definition of diarrhea, going with thyrotoxicosis. But yeah, any just sort of gut upset from the overactive thyroid axis, I think, is possible. And the asthenia too, right? Very, very nonspecific. And so we've got sinus tachycardia on physical exam, which is certainly not very specific for anything. But knowing Graves was in the background and maybe could explain more recent symptoms could help us be even more hypothesis directed on our physical exam for other signs of active Graves' disease. Could the treatment of Graves' disease result in what she's going through now? Graves is usually treated either with kind of iodine ablation of the whole thyroid, which then leads to iatrogenic hypothyroidism, which is something for us to think about, and whether that plays into her symptoms. Often medications like methimazole and beta blockers, and while you're on those, they can have complications. Certainly with methimazole, we worry most about the agranulocytosis, but knowing that she's not been on treatment for a while, other than whether iatrogenic hypothyroidism is in the background, to me, the category of the treatment of the condition playing into what's going now is a little less compelling. And then could that history of Graves put her at risk of any other distinct condition now? I mean, Graves is an autoimmune condition. So is there another autoimmune pathology sort of going in the background? We know she's sort of a predisposed host. Well, it will just be something to think about. If we see her lipase is really high, well, that sort of engage us in thinking about kind of autoimmune drivers of pancreatitis, et cetera. So zooming into this case in particular, I'm not sort of hanging my hat on the Graves being related, but generally when we hear of a significant past medical condition, figuring out how it plays into the current condition, I think that's just sort of the framework I wanted to share. Unrelated, recurrent, and that explains the symptoms. The treatment of it is relating to the current symptoms, or it's associated with another sort of clinical syndrome that's driving things now.
And sorry if I missed this, but David, did you mention that I think a patient like this, again, a non-specific symptom that could localize to a lot of different organ systems. This is a kind of situation where I would slow down and actually do a thorough review of systems, even if the patient hadn't sort of volunteered any more than one symptom. But did you mention that kind of we asked and there wasn't anything else that seemed to be potentially localizing to the heart or the lungs or the GI tract or anything else, David?
Yeah, it was the patient denied any chest pain or dyspnea. She she complained of upper abdominal pain that hasn't any relation with the eating or with the foods. And well, after this was the initial presentation. After this presentation, and I'll tell you more information, she denied really any other symptoms.
Cool.
Great, let's get some more.
Okay, so I'll tell you the first set of labs. The white blood cell count was 9,000 with a normal differential. The hemoglobin was 11.5. The platelets were 130 K. Sodium was 137. Potassium was 3.7. BUN 23. Creatinine 1.2. Calcium 9. Albumin was 3.5. CRP was 15 milligrams per deciliter. Normal is like less than 1. Procalcitonin was 4 nanograms per milliliter. LDH was 190. The liver test, the GPT was 35. The GOT was 30. The ACFOS was 170, and the lipase was normal. She was like mild distress and complained of the pain. So in the ER, CT abdomen with contrast was asked, and they reported like mild signs of pancreatitis. It was like mild inflammatory changes in the tail of the pancreas, and there was also periportal edema, but no other remarkable findings. And I'll leave you there.
Great. Maybe I'll share some thoughts and hear what the group thinks about the labs. And if you want to jump, we unmute? Oh, no. You want to jump in on the imaging then? What do we think about the labs, team? I'll look in the chat for some thoughts. We have a bit of a wish list growing, which we'll get to, David, wondering about the blood in the stool question. I've got a question about lipids from Shusti, maybe based on the pancreatic changes. It's a great thought. My sense of the labs is they don't really help us in any particular direction. I'll say she's 57, so presumably postmenopausal and has a mild anemia, which is something just to sort of add to her problem list and think about what that's from and whether it can relate with the underlying diagnosis, whether there's iron deficiency or anything else. But yeah, I'm looking at the rest of the what you guys are saying here. Oh, and thank you. The thrombocytopenia is mildly there. So actually have a bicytopenia, which is a great pick. Thank you for that, Louis. So mild anemia, mild thrombocytopenia, and our CRP is elevated, right? Signifying significant systemic inflammation, but everything else really looks okay in terms of the liver chemistries. The LDH, correct me if I'm wrong, David, but that is in the normal range. And our lipase is even normal here too. So we've got mild anemia that's normocytic. I'm seeing the MCV of 87 come in, the mild thrombocytopenia there in the context of normal bilirubin, normal LDH. Those are pertinent negatives because a hemolytic process that's microangiopathic and both destroying red blood cells and consuming platelets is an important thing to think about off the bat. And someone with mild nonspecific abdominal pain and asthenia, we really want to make sure that we don't have a consumptive process like TTP, et cetera, here. The low LDH, I think, is reassuring at this point against that. But automatically, these two cell lines down should make us think about unifying causes and get a peripheral smear. But want to mention up front, this all we need is this kind of anemia and thrombocytopenia with the syndrome to kind of put microangiopathic processes on there. And then thank you for highlighting the ALK-Phos. Of all of the liver biochemical tests, we have a mildly elevated alkaline phosphatase. Our approach that we've talked about with prior cases there is, first of all, to make sure we know whether that ALK-Phos is hepatobiliary or not. There's a few different tests that are available, and you can find out what at your hospitals or clinics is most prevalent, but we can get a GGT, and if that's elevated, that would suggest the ALK-Phos is indeed hepatobiliary in origin. At certain labs, you can fractionate the ALK-Phos to see if it's predominantly a hepatobiliary isotype versus from bone versus another source. You can get ALK-Phos from small bowel placenta in someone who's pregnant. So I think figuring out if our ALK-Phos is hepatobiliary or not will be an important step, and we can ask David if we have any of that info. But from there, moving forward, if it is hepatobiliary, that isolated ALK-Phos elevation is what we call an infiltrative pattern of liver injury, which would make us think about a few processes in the liver, any kind of diffuse infiltrative process from granulomatous inflammation, whether that be from sarcoid, TB, et cetera. Syphilitic hepatitis is on the table. Medications, we've heard she's not on any, but we would want to check again. Because really any pattern of liver injury can be drug associated. And then masses and abscess, which we have imaging now that doesn't suggest that, but that's sort of the kind of short list of categories to think about if indeed we've got an infiltrative liver pattern of injury. Anything you want to add or layer on with the CT, which is not totally normal, but I think has some pertinent negatives?
Yeah, I think the ALK-Phos is definitely a signal to me. I never ignore that, even if it's sort of mildly elevated, just because it's coming from somewhere, and serious hepatic disease or serious systemic disease affecting the liver can really only have a signature of a mildly elevated ALK-Phos on the LFTs and nothing else. So always important to image when you have that, and that's kind of that's the segue I'll take into the CT by saying that the findings are non-specific, right? I think there's maybe question mark mild pancreatitis radiographically. The pain is semi-typical. It's in the right place, but it doesn't have other typical features like radiation to the back or postprandial exacerbation. So I don't think we meet the criteria of like 2 out of 3, with the third one being the lipase elevation, right, which we also don't have. So I wouldn't yet necessarily frame this as pancreatitis. And then the periportal edema, I'm not totally sure what that means. I'd kind of want to Google that and see if there's a quick Radiopedia blurb about what it might mean. If we could just have somebody whose name starts with the first quarter of the alphabet Google that and type it into the chat, so that we're not all doing the same thing. But I said I wanted to image the liver, right? And we have an abdominal CT. Well, isn't that good enough? And to me, no, not really. Unless it's a sort of triple phased, appropriately protocoled CT, CT of the liver, it's not quite adequate at appropriately sort of ruling out parenchymal abnormalities of the liver or hepatobiliary system and gallbladder for that matter. Which, by the way, like this could be cholecystitis, in my opinion. It would be an atypical presentation, but just inflammation there that's inflaming the hepatic parenchyma a little bit, that is causing some systemic inflammation, right? And is presenting with pain and tenderness. And anyway, so I think a right upper quadrant ultrasound or an MRI, but easier in most resource settings to start with an ultrasound would really be important here to make sure that there's no focal things in the liver, to get a better look at the gallbladder and biliary tree. And by the way, I also just want to point out that the tail of the pancreas, the head is on the left and the tail goes to the right, right? Wait, no, that's not right.
Opposite on your body.
Okay, opposite. Never mind. So the tail of the pancreas is leftward. Okay, so it's not like there's a common focal inflammatory source in the sort of porta hepatis that could explain all of the findings. So I think it is appropriate to consider sort of processes that could simultaneously cause pancreatic and hepatic involvement and inflammation, and that could be in a category of autoimmune disease. Someone I think had mentioned autoimmune hepatitis. IgG4 related disease, which is one of the manifestations of which is autoimmune pancreatitis, right? But can also cause immune biliary disease, sclerosing cholangitis. It can also cause thyroid disease. Classically, though, it wouldn't be Graves', but rather is it Riedel's or Riedel's thyroiditis? But who knows? It would be interesting to kind of go back and consider whether that episode of quote unquote Graves was actually hyperthyroidism from thyroiditis, and that could still be sort of a unifying theory. And then the other possibility is malignant disease. Again, the inflammation around the pancreas, it's not knowing the quality of the CT, whether there's motion degradation, right? Whether there was how thin were the slices, etc. Can we rule out a pancreatic malignancy that is metastatic to the liver, potentially accounting for some of these abnormalities? So I'll pause there. I'll just might kind of make one more comment about the MCV, which I asked about. I think someone mentioned it would be good to sort of think about B12 deficiency, autoimmune gastritis, which could present both with pain, discomfort, dyspepsia, as well as hematologic abnormalities. The MCV is normal, but that doesn't rule out nutrient deficiency, especially the combination of B12 and iron deficiency. Which is why I was actually wondering about the MCV. It's another kind of subtle arrow to an intraluminal process, right? If a postmenopausal person is iron deficient, which an MCV of 75, for example, would strongly suggest in this case, again, you are once again redirected towards the gut lumen. And the reason I keep kind of coming back to that and emphasizing it is because the way you look at the gut lumen is with a camera from the mouth, right? Or the backside. The way you look at everything else is with cross-sectional imaging. So I think if you do think this is intraluminal versus not, that's a very important kind of branch point in terms of next diagnostic steps and management. So I would still want a B12 level. I would sort of work up that anemia, B12 level iron studies to see where we are in all of those possibilities.
Excited to hear more, Abby?
Okay, great discussion so far. So the patient was admitted due to concern of pancreatitis given the CT, but just in the first days of admission, the upper abdominal pain persisted, and she developed intermittent fever up to 39 degrees Celsius. But they thought it was possibly cholangitis, given also the mild elevation in outpost, although the bilirubin was normal, and they started iptazo. Despite that, she continued with fever, and she started developing another symptoms. She started with bilateral lower extremity edema and mild respiratory insufficiency with mild bilateral pleural effusions. The additional laboratory data in these days, like the serial labs, revealed progressive normocytic anemia up to 9. The thrombocytopenia was also progressing up to 70, 80K. And there was also a opinion of renal dysfunction up to a creatinine of 1.8. With non-nephrotic range proteinuria, and the patient started becoming a bit polyuric. They repeated the CT abdomen, which didn't show any additional findings. The periportal edema was there, and there was also mild ascites, but no clear signs of pancreatitis or pancreatic necrosis or anything like that. They performed an upper endoscopy, which was normal. And I'll give you also the first workup of this fever. The blood cultures were repeatedly sterile. The urine cultures were also sterile. And the HIV, HBV and HCV serologies were negative. They also asked for ANA, ANCA, and antiphospholipids that were negative, and serum protein electrophoresis and urine protein electrophoresis were negative, with no Benson's proteinuria. I'll leave you there. There's a lot to dissect. And I just, I may lose the connection for 1 minute or so, but we'll just reconnect. So keep the discussion and I'll keep you, okay?
Thanks, David.
The plot thickens.
We're only like halfway through the case. This is terrifying.
You want to jump in first?
Sure. I became very anxious, like very early in that aliquot. I think just very quickly, like the patient, with what seemed like a gastrointestinal or like GI, maybe hepatic pancreatic syndrome, suddenly developing respiratory symptoms and fevers unresponsive to appropriate antibiotics. I think just that cluster. This patient's sick. They have sort of like a systemic progressive thing that is affecting distant organs, right? Like, and it could still be a plain vanilla diagnosis, right? Maybe this was early pancreatitis where the lipase, I've seen this a few times, is like initially normal, like 12 hours later, it's 2000, right? So by the way, I would repeat a lipase in this case. And then pancreatitis can be complicated by ARDS, right? So maybe it's still, that's the dyspnea and the pleural effusions and the ascites, like you could just, pancreatitis can cause both severe local inflammation causing a lot of capillary leakiness and severe systemic inflammation causing a lot of capillary leakiness. Rarely does it cause very high fevers in my experience if it's not sort of caused by a super infected or caused by a systemic inflammatory process. But then you're like, okay, there's AKI, and I am curious, W, if you have this, I would take a closer look at this UA. The non-fibrotic range proteinuria is helpful, but it's also not unexpected for somebody with any cause of systemic inflammation. You can get a little bit of glomerular leakiness, spill some protein, but I'd be really curious about red and white cells in the urine, because if there is a signature of glomerulonephritis, right, that can be part of systemic inflammatory vasculitic disorders that could explain everything else too. And obviously the kidneys would be a focal point potentially to both structure the differential diagnosis around, as well as to as a biopsy target to better define the inflammatory disorder. So I think knowing whether we have a potential kind of glomerulonephritis vasculitis syndrome would be really helpful. But I think part of the other reason that I just became a little bit anxious about the patient is because I felt like the case is going in a direction of a lot of uncertainty, at least for me, that there's sort of a flavor of kind of a vaguely defined systemic inflammation, kind of capillary leak syndrome, that I both don't necessarily have a great kind of organized framework or kind of deep understanding of. And it's a sort of a category of diseases that are all pretty severe and can be progressive and you know, and life threatening. So that was my like initial reaction. Let me just let's just process some of the negative studies, right? So we looked for HIV, viral hepatitis, didn't find them. Sort of pyogenic septic stuff. You know, we looked in the blood, nothing. It would be interesting to sort of image the lungs, better understand this kind of overlap of dyspnea and fever, right? And then thought about lupus as well as other autoimmune and vasculitic syndromes, though not like a I don't know if it's kind of a completely thorough evaluation, but the highest yield stuff so far is negative.
Yes, same worry. I'm you know, in real life would really sort of tease out the problems. And I think just succinctly sort of recapitulating those, the edema and the pleural effusions, I guess we don't know yet, and doing iterative exam will be helpful. Is this third spacing? Or have we actually gone into total body volume overload, right? Just looking again at sort of neck veins, IVC assessment will be really important because we don't know with the information we have now, is this like filling pressures are high and thus there's kind of pressure for this fluid to leak out, or is it this leakiness kind of problem that Zaven mentioned? So I think we'd have to do sort of iterative exam for that. We now have a febrile epigastric syndrome. We still have that alk phos that's unexplained, and we want to make sure we've done our workup to evaluate if it's hepatobiliary, and if so, I think really kind of think about kind of that differential further. And then we have this worsening bicytopenia now. I think we need to kind of serially revisit some of the tests that we found reassuring initially. Repeating an LDH, I think, will be really important, particularly in the context of the creatinine getting worse, right? And is the creatinine getting worse part of the primary syndrome or a function of this woman getting sick, you know, having relative renal reperfusion? So I think important is when someone is in the hospital, they've had a broad workup, often really useful to think about, like, what have we done that we want to actually check again? And so I'll second, you know, at this point, the syndrome probably doesn't fit pancreatitis, but second, sort of the lipase elevation, definitely want to get a
That was repeated normal.
repeated normal. Great. Make sure we have a repeat LDH again, because we have to explain these cell counts coming down. And is it really a function of production at this point or consumption? We didn't think we were in the consumption and destruction category, but that's something that we'll have to revisit. Because if it looks like this is really more of a bone marrow problem, we haven't found a source of hemorrhage, we haven't found signs of peripheral destruction, whatever is driving the hepatic dysfunction, whatever, it may actually be something that's affecting the sort of bone marrow as well. Essentially, whatever stuff is in one is in the other. I think finally, importantly, iteratively going back to history, right? What has travel exposure been, right? Our viral sort of mosquito-borne, right, pathologies on the table here. So I think sort of going back and seeing what other exposures this woman has is going to be important, in addition to some of the serum tests we mentioned repeating. And then I think imaging and repeating the exam will sort of help us think about, is this volume from leak versus actually an evolving sort of cardiopulmonary primary overload issue. So David, Debbie, what direction do you want to take us in? Whether they're good. You looked at the chat. You want to share some thoughts from there? Great.
David, 1 second. So yeah, I just want to make sure there's always amazing stuff in the chat, but I think people are also, Steph, wondering about thrombotic microangiopathies, right? Microangiopathic hemolytic anemia, because I think part of the difficulty now is that we don't have like a very clear crystallized problem,
Yeah.
right? Like it's hard to know what line to follow. Like if the LDH did go up and we got a smear, and if there were schistocytes, right, it would be like, okay, this is a TMA.
Mhm.
There's a differential for that. Like we know what the next steps are. If the UA was very cellular, right? If this seemed to be a vasculitic glomerulonephritic syndrome, cool, like we can go.
Yep.
But I think that's the difficulty here. And I also just saw Sarah offering a problem representation, which is awesome. I think that's kind of what we need. And coming in with a sort of abdominal pain, subacute background maybe, and then anemia, thrombocytopenia, and then refractory fevers with possible hypervolemia and progressive cytopenia.
Love it.
That's great. I think let's see if there's any other comments.
Oh, great question about fluids, right? Was there an excessive amount of IV fluids with the initial working diagnosis of pancreatitis? Love that train of thought too. And it looks like David said, yes, there were, but not beyond the first couple days where fluids really at play here.
Yeah. Okay. Go ahead, David.
Okay, just to answer some of the questions you posed, like, well, great discussion. The smear was normal. The LDH rised a bit during the first weeks, but I think it was maximum around 250. The B12 and folate were normal. The TSH was also normal. And during the second and third week of admission, the fever persisted. They escalated the antibiotic to meropenem, but there was no clearly source of infection identified. She developed also mild ascites, and the kidney function also worsened up to 2.4 or so, needing she became oliguric, and she needed starting hemodialysis. During one of the sessions of hemodialysis, she became clearly hypotensive and need ICU admission to start vasoactive support and to do continuous hemodiafiltration. In the ICU, the fever persisted. The kidney function wasn't very reliable due to the filtration, but several trials to stop the dialysis didn't work. The bicytomia also worsened until a hemoglobin of 8. Platelets were down to 20-30K. And PET-CT was done just the day before, so before the admission to the ICU. And what revealed the PET-CT is a small bilateral axillar, cervical, peripancreatic, paraortic, iliac, and inguinal lymphadenopathy, with a Schul peak between 3 and 4.6, and also enhancing spleen measuring 10 centimeters, and reactive bone marrow. There was also mild ascites and bilateral pleural effusions. The patient was needing respiratory support with nasal cannula and ventimask during a few times. After this workup, we didn't know what happened, and the patient also underwent a bone marrow biopsy that revealed mild fibrosis, moderate myeloid and megakaryocyte hyperplasia, and reactive plasmacytosis, without any sign of malignancy or hemophagocytosis. There were no signs. And well, I'll leave you there, and I think there's one more aliquot that may reveal the diagnosis.
Thanks, David. It's always hard when patient gets sicker and sicker and the diagnosis gets more and more elusive. So she's now in the ICU on pressors, needing dialysis without a clear etiology going on. Where to begin substantially? Essentially, everything gets worse, right? The cytopenias, the renal function, her hemodynamics, right? Her kind of whether it's systemic vascular resistance or what. And the fevers are still there despite very broad antibiotics. I think if we go back to basics and think about the inflammatory pathways that drive fever and quickly consider those, is infection at all on the table? She's gotten a really, really great broad antibiotic in her carbapenem. The one thing I'll sort of put out there is if she's at risk for any sort of rickettsial disease, that won't have been covered with the carbapenem at this point. And certain rickettsial diseases as a category generally can cause multi-organ dysfunction and cytopenias. So that's just a infectious category to think about. And then uncontrolled sort of viral replication, sure, but I think so far what she's been most likely to be at risk for has been negative in terms of the hepatitis and the HIV that you mentioned. The lymphadenopathy she's got, it's in a lot of different distributions. And is it reactive or not? Is there a primary sort of lymphoma driving systemic inflammation now? I think is an important question. If any of those are amenable actually for sort of biopsy and analysis, I think that's important since those, correct me if I'm wrong, were active on the PET CT. So I think knowing what's causing the lymph node inflammation could be helpful. And then, because otherwise we've got signs of this kind of severe systemic inflammation. And I had the same thought of someone in the chat is, before we had the bone marrow biopsy, was there concern here for HLH actually? She's fits a lot of the criteria in terms of her high fevers, progressive cytopenias, organ dysfunction. Some of the other lab parameters that can be helpful are extremely high ferritin, interleukin-2 levels, triglyceride levels. But the diagnosis is made seeing kind of hemophagocytosis of cells, usually in bone marrow biopsy, which seems like we don't have here. So I think whether the lymph nodes are going to give additional information is going to be helpful. I think would love to hear your thoughts on the bone marrow biopsy, because overall, correct me if I've sort of misinterpreted what this was, David, but it seems like it's overall hyperproliferative. Am I remembering that right?
Here, mild fibrosis, moderate myeloid and megakaryocytic hyperplasia.
Yeah.
Reactive plasmacytosis without signs of
Hemophagocytosis or malignancy. So what do you think of that? The bone marrow biopsy?
Yeah, I mean, I think it, I would need help from hematologists to interpret that appropriately, but just kind of going back to the context of the bone marrow biopsy. Remember I said, that this vibe of capillary leakiness, right? Sterile inflammation, and which sort of progressed to the point of that inflammation both causing vasodilation, vasoplegia requiring pressors, right? And then potentially, whenever you do develop edema and effusions and whatever, like that capillary leakiness is leaking from the capillaries, right? So part of the hemodynamic insult is also intramuscular hypovolemia. I think that syndrome, when it's not clearly caused by bacterial sepsis or severe pancreatitis, right? Or another clear context like, engraftment after a bone marrow transplant, or differentiation syndrome when you're treating AML or whatever. So when none of that is clearly the context, I think the category of diseases that are just so vague to me, just probably because I haven't seen enough cases or sort of strengthened my illness script with cases enough, are HLH, which, right, is often secondary to something else, sometimes cancer, sometimes autoimmune disease, sometimes certain viral infections, specifically kind of the monoviruses, CMV and EBV. And then the other sort of the diagnosis is Castleman's disease that comes to mind. That again, I'd have to sort of refresh and see how well it fits here, but this like sterile lymphadenopathy, body cavity effusions, and then sort of systemic inflammation, fevers, and I think that's driven also by one of the herpes viruses, six or eight. I always forget. And then the third one is just a hematologic malignancy. So a lymphoma, leukemia, which again could directly cause the inflammation, whether or not they sort of meet criteria for having HLH triggered by the lymphoma is another question. But that's where both the bone marrow biopsy as well as the PET scan interpretation, I think, are really important to understand the degree of FDG avidity in the bone marrow, in the spleen. What is that typical for? And at least in one of our hospitals at the VA, the nuclear medicine folks are just incredible and so expert, and they're super helpful in cases like this diagnostically. And then again, the marrow biopsy. So I think hemophagocytosis is an important criterion, but just as everything else, I think a single biopsy, single test is never fully sensitive. So I don't know necessarily if that rules out what is otherwise potentially a good syndrome for that. And then whether this sort of hyperplasia is just sort of typical to be reactive of kind of systemic inflammation of whatever cause, or if it's still possible that there's a clonal process underneath there and we need to wait on both peripheral blood as well as bone marrow, flow cytometry and cytogenetics to determine, because here's the funny thing, if the bone marrow is so stimulated, like, yeah, like why are the serum platelets 20?
Yeah.
Right. And why aren't we making blood if those cellular lineages aren't, dysplastic, or unless there's a peripheral destruction, which is also possible. So I think I'm sort of at the edges of my understanding of some of these diseases that I think are in the differential. I think more tissue may be helpful, but I think even more helpful would actually be to really take advantage of specialty consultation and talk to people directly to work through the case, and think about what is the best fit for the syndrome.
Yeah, I will just say from the discussion of you guys and the thoughts in the chat, some little like neurons connected for me regarding just Castleman's disease and a consideration here, because it's a benign condition. It's not cancer. So why would something that's not cancer make you so sick? Well, when this lymphoproliferative disorder is multicentric in a lot of different lymph node beds of the body, that's when it can get super inflammatory. And I'm remembering now there's multiple sort of phenotypes of that inflammation, but one of them causes thrombocytopenia, anemia, renal dysfunction, fever. And the mnemonic that sort of goes with that syndrome is Tarfo syndrome. So it's just an interesting consideration. We've got this horrible systemic inflammation with fevers, with cytopenias, no malignancy found in the bone marrow biopsy, yet a lot of PET avid lymph nodes. So I think, yeah, we're definitely going to need the lymph node biopsy and to consider even quote unquote benign lymphoproliferative processes that can still kick off this massive kind of multi-organ inflammation and bone marrow dysfunction. So I think we want a lymph node, David. I don't know where you're going to take us, and I want to be mindful of the time, but would love to turn it over to you for if there's any additional info you want us to briefly discuss or take us through the process of the diagnosis.
Yeah, I'll tell you a bit of the questions you asked, and you stop me if you want me to stop before the final clue. Serologic workup was infectious workup was more profound, like arboviral infections were also negative. Rickettsia was negative. Rickettsia serologies, Coxiella were also negative. There was a positive, I think, or indeterminate IgM for Borrelia, but we didn't think that caused the syndrome. Leishmania serology and PCR was also negative. PCR for Mycobacterium tuberculosis in the bone marrow was also negative. A CT, in the CT there was this lymphadenopathy in the PET, and we asked for a biopsy, that initially didn't reveal any malignancy and was just like hyperplasia, hyperplastic cells, but without any particular finding. We were, as you said, and as was very astutely said in the chat, we were concerned about Tafro syndrome because this picture, I just read about it not short time before this, and the patient had thrombocytopenia, very profound. The patient had anasarca. She was intravascularly depleted, needing pressures, but because the hypertension was so high, because all the volume of the intravascular space went to the interstitium. The ultrasound was remarkable for that also. She was also with fever and marked high CRP, high also procalcitonin. There was renal dysfunction, mild reticulin fibrosis in the medulla, and there was organomegaly that is typically mild, small lymphadenopathy and with low uptake in the PET, such as in the Tafro syndrome, unlike the lymphoma picture. And we get another lymph node from the inguinal zone, and it was consistent with Tafro, with hypervascular hyaline inflammation, and we even before start given the achieving the histologic workup, the patient was very profoundly ill, so we started high dose steroids and tocilizumab, and progressively she started recovering, so very happy ending.
Wow.
Wow. David, will you, this is a subtype of multicentric Castleman's. Can somebody remind us the sort of the pathophysiology? Is it virally driven?
This is a subtype of idiopathic multicentric Castleman disease. I didn't say that in the biopsy the herpes virus 8 was negative. You have to exclude it also. We also did, I didn't tell you because, the workup was very large, but CMV and EBV serologies were negative. The DNA of CMV and EBV in the serum was also negative. The origin of the pathogenesis of this syndrome is not well known, but there's hyperinflammation driven by IL-6 and VEGF, with a picture, I think similar to a cytokine release syndrome, but or even HLH, and with features of capillary leak syndrome, as you said. And I think that the key question here is that unlike the other variants of Castleman disease, even multicentric, the multicentric Castleman disease associated with POEMs or with the other types, IPL is another type, are more chronic or subacute, and this is more acute and tend to present into very acutely ill course. So
Wow, awesome teaching and just boiling down very complex pathophysiology. Really appreciate that, David. Parisa, we'll turn it over to you for some teaching point summary.
Thank you so much. It was a great case. Sorry, I'm not opening my camera. My connection is a little unstable. It really feels like I'm watching live NEJM cases. Anyway, we started with the patient who has upper abdominal pain. We learned that we are facing with this syndrome. It could be localized to GI, like dyspepsia, reflux, or any systemic illness like cardiac causes or pancreatitis. We learned that red flags of abdominal pain are usually long duration of the pain, severity, any abnormal vital signs, or any accompanying sign like melena. This patient specifically has a history of the Graves. We also addressed that in this context, maybe she is presenting with recurrent hyperthyroidism because she was not receiving any treatment, because this could be present with GI hypermobility. It could be also in the context of treatment side effect. We talk about different kind of treatments in Graves, iodine ablation, which is causing iatrogenic hypothyroidism. We talk about methimazole and ruling out agranulocytosis, and also beta blocker is another treatment in the Graves disease. And because Graves is an autoimmune disease, we also need to pay attention to other autoimmune disease in these patients. We also address anemia plus thrombocytopenia. We need to think about any microangiopathic process. We need to think about hemolysis. We need to check LDH, bilirubin, and peripheral blood smear. This patient has elevated alkaline phosphatase. We know that the resource could be hepatobiliary, which GGT will help us to guide us through these things. And also it could be from bone, a small bowel, or placenta in the patient, someone who is pregnant. We also talk about pancreatitis that could present with postprandial abdominal pain and elevated lipase, and it could be complicated with ARDS due to local and systemic inflammation, because these specific things could cause capillary leakage. We also mentioned hepatobiliary system plus involvement plus pancreatic involvement could be in the context of any infiltrative disease like IgG4 related autoimmune. This patient has thyroid problem. We were thinking about these things. We also talk about glomerular leakiness, glomerulonephritis, vasculitis, which have cellular UA. We think that when we are facing edema plus pleural effusion, we need to think about third space fluid accumulation. We need to do a thorough exam. We need to look at the jugular vein, IVC, and feeling pressure. This patient has a worsening by cytopenia. We know that we need to repeat our labs. We need to recheck LDH, creatinine, because the source of the worsening by cytopenia could be hemorrhage, hemolysis, or any bone marrow involvement. We know that when we are having fever and we are treating the patient with antibiotic, but we are not receiving any response, we need to think about inflammatory process, and also maybe it is rickettsia, which is not treated usually. We thought about because the patient has high fever, progressive by cytopenia, organ dysfunction. We thought about HLH, and we think that it could be due to cancer, infection, specifically CMV and EBV. Also, we learned that, for example, in AML, patient could have HLH, but because of underlying inflammation, not because of the cancer. We talk about capillary leakage syndrome, which is happening because of the cytokine release and intravascular hypovolemia we are having, and vasodilation. The pathology behind that is sepsis, differentiation syndrome in treating AML as well. This case has been diagnosed with TAFRO, which is a variant of idiopathic multicentric Castleman disease, and the symptoms are thrombocytopenia, anasarca, fever, renal dysfunction, and organomegaly. The pathophysiology underlying its cytokine dysregulation, specifically interleukin-6. It could be also autoimmune disease and infectious causes. Thank you so much. I learned a lot.
That's awesome.
Yeah. So what a great summary, David. Thank you for an awesome case, and really appreciate all of your time, everyone else being on the case with us today. Always a ton of fun, and we look forward to next time.
Thanks for subscribing, Ethan.
Bye.